there are people who have to get on, and they're not obviously going off in the next 5 minutes, but we need to give the following papers due consideration, and we need to make sure that, as I said earlier, we scrutinise, challenge, and question what's coming ahead of us. We owe it to the people who put the papers together. We owe it to the people we are consulted with to make sure we give it proper consideration. Okay. If needs be, we will adjourn and we will return and finish it off. I don't think MD particularly wants that because I think we've got the knowledge here, we've got the continuity, and I would like to, if we can, finalise this today. So based on that, we're moving on to item 8, which is presentation of the findings of the Right Care, Right Place programme for Kirkcudbright Hospital. And I can confirm to members that the second of the findings will relate to the future use of the hospital. Need to advise members you've received the pack for the site containing detailed analysis of 6 options consulted on for the site, plus the hybrid model suggests to 5 people from the local area, and in the additional option proposed by the Police and Galway Council following that consultation. You've been asked to confirm that the process to date and associated outputs are consistent with the requirements of Direction 2302C to develop a way forward for the use of cottage hospital sites. To confirm, it is assured that the process of engagement and participation and the consultation process itself have been conducted appropriately and in a way that is proportionate to the subject matter in line with the planning with people guidance. That we approve the recommendation to progress option 3, Community Health and Social Care Hub, and issue the attached draft direction to establish a community health and social care hub in Kirkcudbright Cottage Hospital, including allocating a budget to deliver it. Now, Health Improvement Scotland have suggested that we should, in reviewing the analysis, take account of, I'll go through it. 1, analyse and consider the feedback from people and communities, recognising that although the options for each hospital were considered as part of one public consultation exercise, there are different nuances and context for each individual cottage hospital location, and therefore the decision that IJB makes for each may be different. A respondent to the phone interview said there are 4 hospitals involved in the consultation, they're not all the same. And I think we've already had that conversation in relation to the difference in each of them. Need to explain how the hybrid model, which is a combination of options 3 and 4, being put forward during the option appraisal will be considered alongside the consultation feedback. And I would hope that you all understand where I am with that now. If as I'm going through this, anyone has any questions, any queries, please stop me. They should now consider how you can address concerns raised around capacity for people to receive inpatient care in the Police and Galway Royal Infirmary and the remaining cottage hospitals. One attendee at Kirkcudbright in-person event observed there's people in DGRI who don't need to be in DGRI, but there's nowhere else for them to go. Similar concerns were also raised at other in-person events. At this point, I'm going to turn to Nicole to see if she can assist me in relation to the delayed discharge issue.
Yeah, so as highlighted previously, just for due diligence again, just in terms of process, our delayed discharges are out of sync with the rest of Scotland for our standard delays, and over the last few months we have been required to make improvement. What we have seen at the height of our delays, we were about 100 to 120 at the maximum, and today they're in the low 70s, and that is due to work across the Health and Social Care Partnership from staff. And I absolutely want to recognise the work and effort that staff across the partnership have put into the work to improve that, which is looking at sustainable solutions, looking at things that will hopefully prepare us for winter and take us to that improved position. So just to highlight 3 main pieces of work that's been taken forward in the short term in order to improve that position, and one that is a longer term piece of work that is now started and again will continue to evolve. So the first one is the application of discharge without delay principles within our hospital settings, both our acute sites and our community sites, which means that from the date of admission we begin the planning for a discharge, working with family, unpaid carers and all multidisciplinary teams to make sure that that discharge is as smooth and timeless as we can make it. What that also does is improve people to become not a delayed discharge, so that we hopefully endeavour that people never become delayed in their pathway and journey of care. But also what we have seen is an improvement in our non-delayed patients that wait in hospital more than 14 days. So we have seen a full improvement in terms of some of that application and benefit of applying that Scottish Government best practice guidance. The second piece of work has been around about our care homes, and our social work colleagues have done a huge amount of work to review the standing operating procedure in terms of the choice guidance and what that looks like in terms of intern placements as well. And we have done a huge amount of work across the multidisciplinary team in terms of how that flow to our care homes works. And we have seen an additional 10 beds brought on stream, which are in addition to the flexible beds that I discussed at the Right Care, Right Place, with 5 of those beds being available to us in October and a further 5 in November. And then one of the most significant pieces of work is that process change, which is about our care at home pathway and that discharge to assess process, where we heard earlier about the home first principles and how people recover best at home, surrounded by a familiar environment, whether that be pets, pictures of loved ones, and that is best practice in terms of doing that assessment for ongoing care if required in that homely setting. And we have been working with providers to increase capacity, and we heard Steph earlier talk about a 10% increase in the care at home capacity that we've got. We're also absolutely looking at how we use technology to have that blended support in terms of care at home, so that we protect the hands-on care for where we need it most. And then the fourth piece of work, which is a wee bit longer, is the use of the virtual ward, which again is a model across Scotland, particularly for our frail elderly patients, but it is used in other elements of our service at the moment, where we manage people at home with outreach from the clinical team in DGRI, and we use remote monitoring and the expert input from the acute team to manage people at home. And again, the evidence base for that is strong. So in my view, the reopening of inpatient beds on this site would not improve delayed discharges, and for us to move somebody to that site, if they should be at home, they would still be classed as a delayed discharge. And we should absolutely be doing things to get them to that right place in terms of home, if that's where they should be. I also have concerns that if staff were pulled back into support in the hospital site, that who would be the support for them at home would be reduced, and therefore we may have social admissions to the hospital sites, which would be a delayed discharge from the point of admission. So my view, Chair, is that the option to reopen inpatient beds does not support or improve our delayed discharge position at all.
But an option 3 doesn't.
The option to reintroduce inpatient beds doesn't.
Can we turn to our professional advisors and ask them for their appropriateness, or their views of the appropriateness of reopening inpatient beds?
I think I would add on for supporting and what Nicole said around those delayed discharges. Again, it goes back to all the clinical arguments that I presented this morning, that we know that we want patients cared for within that home setting, with the services wrapped around them in the home space. I think it's supposed to delay them further. There is no value stepping patients into a space and delaying them further. And not only is there no value, it hardens the patients. And I think that's the key information that I need colleagues to retain, and I've had that discussion. I don't want to rehash discussions that we've already had.
I appreciate what you're saying, but I do think it's important, because there may be people who tap into the meeting or who only tap in to listen to perhaps their local area, and they may not have heard that. So what we're doing is making sure that everyone has the opportunity for their area to hear the same argument. So I understand that I'm perhaps asking you to repeat yourself, but it's purely for the context that the people who will have an interest in Kirkcudbright and Thornhill and Moffat get to hear the responses from us without having to sit through the whole meeting. So I appreciate that. Thank you.
And so to that end, then, was what was said enough to cover that base, or would you like me to?
So,
To reiterate what I've said this morning in totality. I mean, I think just to summarise that, it's about the clear that the evidence absolutely supports the patient should be covered in the homely setting and not within a hospital-based setting. And by stepping people down from one place to another when they're fit to be discharged is harming them and not actually improving their level.
okay, appreciate that. Thank you, Mark. Okay, so we should ensure that additional impacts for each locality identified through the options appraisal and consultation process are included in the updated impact assessments and are fully considered throughout the decision-making and implementation process. And at this point, Viv, Steph,
Yes.
do you wish to give an insight on that?
Thank you, Chair Brigade. We have revised the equality impact assessment. We would generally do that as things progress, good practices that continues to reflect any issues that arise. So we have done that within the equality impact assessment for the recommended option 2, you have option 3, and that's within your pack here. And since it was issued to you, we've also updated that further to reflect what came back from his. So that is all in there and included. So we have done that. And if there are any additional things that come forward out of today or as we move forward into implementation, we'll also do that and make sure that that's all recorded. And it's all considered published publicly.
Thank you. We should also demonstrate how the board has taken into account the concerns people have raised about challenges to accessing services due to limited public transport, travel, distance and costs. And I think that we are confirming that we will work with local partners to establish accessible and integrated transport networks. And I think it's, as we mentioned in the previous one, you know, there's a whole range within the direction which would include that. And that's going to go to the next meeting of the Finance, Performance and Quality Committee. You also recognise the concerns expressed by some people during consultation around the perceived erosion of local services and consider how these concerns may be addressed. What we would say that option 3 would offer an increased range of outpatient services and outpatient treatments in the first instance, with a commitment to look at wider service areas for future development, and so it is upscalable. Should also acknowledge that during consultation, people have consistently expressed an importance and high value attached to inpatient beds in their local communities, and I think we've seen that expressed already. So I'd ask that we do give that due consideration. Feedback, we should also give feedback to communities on each of the decisions reached, how the IJB conscientiously considers people's views and financial considerations have impacted on the decision-making process, and how the issues identified, for example, travel and access, may be addressed going forward. If the proposals are approved, we then recommend the following areas are considered during implementation. Bear in mind, this is the Health Improvement Scotland recommendations. That we continue to co-design solutions with agreed timescales with people, communities and partners to help mitigate adverse impacts identified through the consultation responses. Impact assessments and Fairer Scotland duty, for example, to transport and access. We should also recognise that the commissioning process ran in parallel with public consultation, and this may have resulted in some changes in how the intermediate care model will be implemented. If the changes are substantially different, there may be a need to consider further communication and engagement with affected stakeholders. And the IJB will include details of the commissioning programme for flexible beds as part of this communication in the decision that is reached. All stakeholders are offered the opportunity to be meaningfully involved in the implementation of the decision, and I commit to doing that. Now I pass it to Viv and Steph to give us a presentation in relation to Right Care, Right Place in Kirkcudbright Hospital.
Thank you, Chair. So yes, I'm going to start off here with you, first of all, with an apology, which is not always a good thing when you're presenting a paper, but there are a number of errors that haven't been picked up in terms of typos throughout the paper. So I just wanted to highlight those to members and that we're aware of them and make sure that you're aware of them. In terms of how that happens, I suppose that's really, you'll see there's been a lot of papers that have undertaken here, and there are areas of similarity between one paper and another. So I think where things have maybe been copied into one place or another, and then as we're reviewing those and taking those through, I think you get kind of a bit bug-eyed, we might call it, or a bit word-blind to things. So I would ask for your patience with us around that. But I can highlight to you that this particular paper, page 38, page 39 and page 43, state Stuart rather than Kirkcudbright, which is what it obviously should be. And within the direction at the very end on page 53, we refer to the markers rather than to stewardship. I do want to reassure you that these are all individual papers that are in there, and that's just down to that human error. We have since also noticed that there's a slight change in the figures for the on page 6 of the executive summary, where we're talking about the cost of an inpatient and hybrid beds. Those are not the correct figures, and actually it should be £200,000 for inpatient care and 514 for the hybrid care. So thank you,
What
Chair.
page was that this?
That's on page 6, so at the very start in your executive summary,
Okay.
in the section
Yeah,
that's about
thank you.
considering the way forward. Could you just repeat those figures? Sorry. Yes, certainly. This is so inpatient is 200,000 and hybrid is 514,000. I will say that throughout the rest of the paper, those figures are correct, but just on that particular exec summary, we've made an error there, and apologies for that. Okay. So if I set out really what I'm going to do is take you through a bit around the process and try and describe what we've done to try and make this kind of complex landscape perhaps hopefully easier to digest, and try to bring some consistency and objectivity to what we're doing. Just to remind colleagues of the request that came from you to us in September 2023, was that we give appropriate consideration to the level of engagement and consultation required to work with communities to develop a way forward for the use of hospital sites, specifically with the suspended inpatient services. We worked with communities to develop 6 options in relation to that over the course of the winter last year. And in March 2024, you approved 6 options to be undertaken, to be subject to options appraisal and wider consultation. Those were the status quo plus, community health and social care hub, the establishment of inpatient services, noting that for Kirkcudbright Hospital that would be the opening of 8 beds, community ownership, and to close the site. During the option appraisal process, there was a suggestion for a more hybrid model be considered. That's described fully in how that came about within section 3.5. Appendix 5 is a full description of that. And that was about a kind of blended approach between the inpatient and the community hub, with a proposal that there would be for Kirkcudbright Hospital 2 beds with the potential to surge to 4 beds if that was required. As part of the formal response to consultation, our colleagues at Dumfries and Galloway Council proposed a slightly different hybrid blended model, and section 12, page 36 provides more detail on that, and that has been subject to areas of the assessment that we could do, obviously accept the option appraisal and consultation. And that was for proposal for 2 respite beds and 2 palliative care beds across all 4 hospital sites. What we have undertaken, and I want to really reiterate the amount of work that's come from a number of teams across the organisation. There's been a lot of people involved in bringing this to you, so I hope that it does bring the objectivity and around it that we would hope. But we've undertaken to look at 6 different elements of analysis for each of the 6 options, the proposed hybrid model and the Dumfries and Galloway proposal. Option appraisal was not able to be done for the hybrid model because that had not had all of the robust analysis and information put together in order to do that, nor was that possible for the Dumfries and Galloway proposal. But we have undertaken that, and that's shown to you in our analysis. The consultation results were analysed, and for Kirkcudbright that was based on 290 surveys, 16 of those were from staff. And the remaining 4 assessments are around a financial appraisal, workforce appraisal, the views of our professional advisors to the integration joint board, who are obviously here today, and views of the operational management team, and on the assessment of the deliverability. What I will say is that the option appraisal involved stakeholders, including members of the public, people who deliver services, and people who manage services. The consultation was obviously, as I say, on responsive of those survey responses. The financial appraisal was undertaken by our finance colleagues under Katie's direction, and the workforce appraisal, the Right Care, Right Place team did that, but then had support from the workforce director and from the employee director of NHS and Priest and Galloway to take that forward. And the views of the professional advisors, say they are here. The operational management team, they're also represented here today too. So obviously with 6 elements and 6 options, there's quite a lot of information there to do. So what we've done is looked to and adopt a red, amber, green or RAG rating for each. And there within the paper, we've described what that means for each one. And essentially what we've done is we've tried to give criteria for each of those 3 ratings for each of those, and I'm happy to go into further detail about that if required, how we came to that. What I will note, point of note for you, is that within the cover paper, all of those assessments are reported by the option, so that you can see by option around each of the assessment. But within the appendices, what we've done is we've looked to present that by the element itself. So, for example, if someone wanted to have a look at the workforce aspect of a particular option, for any of the all of the options, you can do that by looking at the appropriate appendix. So, as I say, hopefully that's brought some consistency and objectivity and some scientific rigour, I suppose, around what we've tried to do with that assessment. And Steph will now take you through what the results have been for the Kirkcudbright Hospital.
Thank you, Viv. So in relation to all of the 6 elements of assessment, just in summary, it's clear that options 1, 2, 5 and 6 are not favoured. Option 4 favoured well with the stakeholders in terms of the options appraisal process. However, this is an unaffordable, unsustainable model and is not deliverable. It also does not reflect the ambition of the Right Care, Right Place transformation programme, our local and national and strategic direction. The hybrid model, which is for Kirkcudbright, is a blend of option 3 and 4, which is, as Viv has said, it's starting with 2 beds with the potential to increase to 4 dependent on demand. Also rated well with the stakeholders and is deliverable with some risk. However, the caveat to that at this point in time is that risk is likely to increase in relation to the workforce challenges in both the short term and the medium term, and therefore it's likely will become unsustainable very quickly. The high costs for the hospital beds and elsewhere means that this model is not delivering best value and presents significant risks. There is a high likelihood that this model would have detrimental impacts on other areas of the system, and particularly our ability to provide that local care and support for people at home through the home teams model and the introduction of flexible beds. There would also be an impact on our acute services. This hybrid model also was not favoured by the professional advisors in terms of quality and safety. So in terms of the recommendation and the rationale for that recommendation, which is highlighted throughout the paper, the assessment of the 6 options, the hybrid model and the DG Council proposal has identified the option 3, the Community Health and Social Care Hub, as a recommended option. The reasons for that is that firstly, this offers greatest benefit overall. It aligns with the IJB model of care and strategic commissioning intentions and supports the ongoing transformation of community services. It will deliver significant recurring savings of £644,000 per annum, contribute towards the financial recovery plan. In relation to best value, in terms of the bed cost, £50,000 per annum for a flexible bed compared with £200,000 for a hospital inpatient bed, or the £514,000 per year for the hybrid model in the DGC proposal. It can be delivered and it is sustainable from a workforce and operational perspective. While the public view is that option 3 does not meet their needs in terms of a bed-based care, however, there are flexible beds, intermediate care beds and hospital beds within the locality area, hospital provision being provided at Castle Douglas Hospital. Shifting the balance of care from beds to home-based services is the direction of travel and fundamental to the community transformation work ongoing since 2021. The professional advisors to the IJB have expressed their belief that option 3 offers safe, effective care in line with local need, while having the potential to improve public health and tackle inequalities. Community Health and Social Care Hub has the potential to grow and develop in line with the needs of the community, digital capability, future innovations as they arise. There will be opportunities to expand the range of care treatments, outpatient appointments, early intervention and preventative approaches, and integrated care and support by extending the home teams to combine statutory, independent and third sector mental health support, as well as new practices such as holistic person-centred styles of care, such as day hospice. In relation to Kikubi, there's also a unique opportunity whereby we do successfully deliver day treatment in the form of a satellite renal service. And it's how we expand in terms of day treatments and utilise that accommodation when renal are not using that for dialysis. So there's real potential there. The other unique factor for Kikubi is that your GP practice is adjoining through the doors of the facility, which means that that local GP practice is within that hub setting, and that will lend itself to joint working opportunities with the practice multidisciplinary team. It will provide enhanced interactions and joint working with a range of community services. Subject to IJB agreement, plans for further development of services within the Community Health and Social Care Hub will be explored with teams and local people before bringing forward fully costed proposals for consideration in the strategic commissioning decision. Thank you for your attention in this matter, and we're happy to have any questions that the team that the IJB may present to us. Thank you.
Thank you for that. Can I have any of our professional advisors in relation to so far in relation to the hospital, please? Ian?
Thanks, Chair. This will sound repetitive for those of us who are involved in the meeting, but I think it's important for the folk who live in Kikubi to hear this as well. So Mark made some excellent points around hospital being really detrimental to people's health when they shouldn't be there. And that's my experience as well as a social work and social care professional. People who stay in hospital for longer become cognitively and physically impaired to a disproportionate degree, and that's actually counterproductive to the whole system. I think the work that Nicole mentioned around delayed discharges is come to fruition locally, and we've got to maintain that, and we've got to do things differently moving forward. Steps also quite clearly outline the importance of having care, whether that's health or social care, in communities and closer to home and in people's homes, and that's absolutely, my professional opinion, that's the right thing to do as well. Couple of inputs earlier on today made reference to myself as Chief Social Work Officer supporting the hybrid model in Kikubi, but what I said is I would support a hybrid model, not the one presented, because I've been clear about not having inpatient care, because in my experience that doesn't give the best outcomes from a whole systems perspective. So I did ask for consideration for a social model to be costed. Having said that, what we've looked at today is the costings for a small number of beds, the amount of people that would need to be employed on a registered basis would be similar to what we see. Would be less potentially, but would be similar to what we've seen for inpatients. So given the financial position that we're in, that probably isn't valuable, which I did say earlier, Chair, that my considered opinion has evolved as the days gone on, listening to other views. So that's what I was saying in relation to this. Therefore, option 3 from a professional perspective, from social work and social care, is critical. I think the specific element within there, though, is listening to what the communities say and what the communities actually need as we move forward. And I think that's captured within the direction.
Tracy?
I think
as a strategic board, we have a responsibility in terms of not only thinking about the present, but thinking about the future. And how do we prepare ourselves for the future and the challenges that that brings in terms of understanding for communities and the feeling in terms of losing services and the historical nature of some of our hospitals and the way they feel to people living in those communities, being here for nearly 20 years. I understand in terms of our desire to keep things as they are, but the challenges that we face as a health and social care partnership as we continue to grow older and as we continue to have more challenges at our workforce and sustaining our services, we need to ensure that the workforce that we need is best utilized, and we need to ensure that we are fit for the future. And the transformation that we had in the community and continues to happen in the last few years locally, and all the different models and all the different pieces that are evolving, they do require some focus back to the community and someone else. And we did say some of this earlier about that shifting that balance of care. And I think Steph referred to that. It had to be with actions. We have talked about this for a very long time, but we continue to focus on the acute care. But it's with this, there is an opportunity for us to think about, as you said earlier, Steph, about that community hub, how that may look like in terms of that GP at the heart of, with the expert medical generalist role at the heart of that community services alongside with the home teams. And the risks that we have in terms of going back to inpatient services is that some of that expertise and skill is being utilized in home teams and other community services. So is that need for us to look to the future while managing that uncertainty that we are not there yet with the flexible bed model, intermediate care beds and all of it, but also acknowledging that we will need to kind of keep an eye closely in terms of us as we evolve on how best for each community hub, what sort of services or teams we're going to be there to best utilize the resource that we have. So that is what I wanted to bring to the IJB in terms of that, not only with my medical primary care hat on, but as a strategic board member, not voting, of course, but that overview of the system and the need for us to actually do what we say. Thank you.
Yeah, Gracie, thank you. Anyone else?
So, yeah, all Gracie. But I guess I'm probably going to echo a lot of what Gracie said, but it's that looking at modern health and social care and what that means. When we know we have a restricted budget, we have to ensure that what we're spending our money on is doing the best we can for the most people. And I think in these communities, if we aim to use that budget to provide a small number of beds, we will be, seriously under-treating or under-supporting other members of that community. And that's why I think the option 3 with having the community hub, where you can have, hopefully a wide range of services that mean the people of Kukubari and our surrounding area will have to travel far less than they currently have to and have much more provided locally is a much better model. And it is that the modern health and social care is about hopefully fairly short stays in hospital and getting home and being supported at home, whether it's be rehabilitated or of ongoing treatment. I think the model of where we have more beds will, as Mark has already highlighted, you actually will be doing people harm. And so I appreciate in communities, this is the concept of having the bed base is something that's really valuable to them. I think the values in the building and how we use the building, not necessarily in the beds. So yeah, that's what I was
Okay, thank you. Well,
Yeah, thanks very much, Amanda. And again, I appreciate how difficult a decision it is for the IJB. The action that they really that presented today really showed the passion that there is in the community about this issue. I did listen to what the individual said and read the consultation analysis responses, but it's still my position that I would support option 3 because I firmly believe that will bring a wider range of service to a greater number of people that will benefit from that option. One of the issues that was raised about was about transport, but it's not just about transport to inpatient services, it's about transport to a range of health and social care services, and I think having that that community hub model lends itself for more people benefiting from that. I think probably as well from a population health perspective, we have a limited amount of money to provide health and social care, and when we're looking at population level provision, we have to look at best use of resources. And from the financial analysis that's been done in terms of the hybrid model, that doesn't look to need to be the best value of resources. I'd also be concerned, I think it's quite clear, the hybrid model was one that the community were supporting, about the impact that would be in the restriction of other white broader services that could be delivered, because that would have an impact on the space available for them as well. So it is my belief that option 3 would provide that real opportunity, as Lee and others have said, really to develop that model of community based care that we need our modern health and social care services to deliver. Thank you.
Okay, thanks all. Okay, open to members to ask questions.
I have a couple of questions. One is in regards to the survey, that we did the postcode split. Most of the respondents are from DG6 Kukubri, which makes sense. The other stewardry one, do you have a split in regards to where they are? Because some of the DG7 is quite close to Kukubri from a location point of view. So I'm just wondering if there is more DG7 than other stewardry ones. I'm sorry. It's quite specific.
I think I might ask Kerry to answer that, if that's okay, because she did the analysis, but my suspicion is we only asked for the first part of people's postcodes rather than get into anything that was.
Well, it would be DG7 that I'm interested in, because that's closer.
Chair, do you have to ask Kerry to?
Yeah, Kerry, can you assist us with that one?
Yeah, I can confirm that it was largely the DG6 and 7 postcodes, which were the majority of respondents. Also at the events, we noted there was a lot of people who attended from the kind of gatehouse area as well. So yeah, I hope that's helpful.
That's very helpful, thank you. That confirms my suspicion, because just from where it sits, the postcode doesn't necessarily line with the boundaries of our locality. And my second question would just be for Gary, just so that we are consistent. Gary, if you could let us know the flexible beds, how many in the area have been commissioned to date, and what was the target for the area?
Well, what we're aiming to do is get 5 flexible beds. At this stage, we've got a commitment from local care homes to provide 2 flexible beds. I think the moving forward, and I suppose just harking back to Stephen's point before, initially we're looking at care homes providing flexible beds, but what we're starting to do, and we're going to do this in the Strangor area, we want to look at sheltered housing schemes which can provide 24-hour support.
We're completely here yet this end, sorry. There's other people can't quite hear.
Okay, so we just go back then. There's going to be two care. Yeah, no, but okay. We just go back. Sorry. We're aiming to get 5 beds in the stewardry area. We've currently got a commitment for 2 beds in care homes. So clearly what we want to do, and those 2 flexible beds in care homes should be available in the new year. But moving forward, in order to get to 5 beds, we want to look beyond just using care homes for flexible beds. So we are going to explore the possibility of using sheltered housing schemes in the stewardry area. We've done something similar in the Strangor area, where we've got we're planning to have a flexible bed there. And I think across Dumfries and Galloway and in stewardry, yes, we're going to focus on care homes initially, but we will be looking, because they've got limited capacity in the short term, we will be looking at provision within sheltered housing schemes as well.
Okay, thank you very much.
Okay. Emma?
Thank you very much, Chair. I just wanted to ask about the step up, step down care, and whether those people in those places in the care homes will be linked in to the services that the care hubs will hopefully provide as appropriate, because obviously we don't know what that's going to look like yet, but will that all be linked in for those people in the step up, step down care beds?
So we've got two spots.
Yeah.
I think the two responses to that within flexible beds is that one, yes, they will be part of that wider community within the care home. I think the other thing though I want to stress is that our home teams will be providing in-reach support to the residents in the care homes, and for people who are there on a short-term basis, it's important that their skills, they don't get deconditioned and that they don't become less independent. So we will be working with staff within the care homes to work with people to enable them to return home. So it will be a slightly different service within the home, but the resident will have access to the full range of services within the care home.
Chrissy?
Yeah, thanks. So a couple of things. So you've just mentioned about sheltered housing in Kilcoogry. I wasn't aware that there is any. I don't know if you could allude to where that is, please. And given the continuous concerns about the care home provision across the region and the various care inspector outcomes and monitoring being in place, do you believe that this is good measure and best value to be purchased in these homes?
So
That's my first question.
the first question, I missed the second part of your question, sorry, but the first part in terms of Kilcoogry and sheltered accommodation, the point I was making that initially we did a tender exercise at the beginning of this year and we invited care homes to bid for flexible beds. And we've had quite a good response. Our next stage, particularly in the Kilcoogry areas, we recognise that there probably aren't going to be as many flexible beds as we would like. So we want to broaden the pool. Offhand, I don't know what might be available within terms of sheltered accommodation in the area. And it may be that we have to go back to care homes to see if they can provide more flexible beds than the current things of two at the moment.
So at the moment, the answer is that we don't know if there's any sheltered housing, even though it's been just put on the table now, and we're not procuring the beds. Can I ask, are the beds in the?
No, my point in a way was that we want to be creative, and what we're going to look for is that there's a plan for the next 12 months. But Right Care, Right Place is a programme for the next 10 years. So what we'll be looking at is to commission flexible beds within care homes, but where there are suitable sheltered accommodation, which may be available now or may be available in the future, we will tap into them as well.
And I'll just come in the back of that. So I suppose sheltered housing, what we're really talking about is extra care housing, and then Stewartry. And what we've done recently is, if you'll have noticed the new development at Spring Home, it's not sheltered housing, it's a housing development, and we've secured block contract for care and support through a provider. So it's about utilising the provision of care and support in an area like a housing scheme. It doesn't have to be sheltered housing, but it can act as extra care housing within that scheme. So we've successfully done that, and that's Spring Home area. I suppose what Gary's alluding for Kilcoogry, it's something that we need to look at in terms of that housing potential. And I think the focus in terms of our focus has been in the procurement of beds in the care home setting, but we do need to widen that because there is potential opportunity. There's also one development in Stranraer about to take place as well. And again, we've got the extra care schemes in Moffat, which I think the community groups alluded to this morning about where they have been purposely built and commissioned 24 in the Moffat area, and the same in the Lanham area. So there's potential there. Thank you.
In a sense, you had another question.
Yeah, thanks for your answer. It just didn't really answer what I was asking. What will we do if we can't procure these? Because we're obviously hearing that there's a problem procuring these. But that's fine. So my next question is, what weight do you give to the intervention of the local GPs in Kilcoogry, as they know their community's health and social care needs and understand the value of the cottage hospitals? And from what we heard this morning, they seem to be on board with having the hybrid option. And I know I'm going on again about the hybrid option, but I need to exhaust all of these questions. So please bear with me, because
the community again are very passionate about having the palliative care option, having the respite beds, and the GPs are on board with it, the staff seem to be on board with it, and the community do. So what weight are you giving to this? Where are we? Is it just the finances that's the barrier, and the staffing? You know, what weight are we actually giving to what the GPs, the doctors are giving us advice on?
So the hybrid models for the three areas, Newton Stewart, Kirkcudbright and Thornhill, have all been given the credit and kudos in terms of that stakeholder group step forward. And that has been, I think, evidence today in terms of what's been presented around the hybrid models going through exactly the same process. What I would say specifically for Kirkcudbright is that Castle Douglas Cottage Hospital serves the population of Stewartry very well in terms of inpatient beds. And it is relatively close to Kirkcudbright. It's 10 miles. It's not a significant mileage. Now, I appreciate for everybody, it could be significant mileage if you haven't got access to transport or you haven't got family or others that can take you to visit relatives. But at this point in time, our service at Castle Douglas Hospital serves that population in terms of inpatient beds. As I say, we have in terms of that hybrid model that the stakeholders have been the GPs that have stepped forward in relation to that. 2 beds, if we look at the fact that the stakeholders group for Kirkcudbright actually, their position was 2 beds in terms of inpatient services with a view that they would open up to a maximum of 4 beds dependent on that demand. So there's a bit for me where that GP cohort understood the needs of the population and the fact that they stepped forward for a 2-bedded option with the ability to flex up to 4. So we've got 2 beds in terms of the flexible beds, and we also have that inpatient service at Castle Douglas. Thank you.
Any other questions, Vicky?
So I kind of feel like I'm arguing with myself a wee bit over this. So I would ask the same question as I asked in relation to Newton Stewart, as in what comms are we doing with this local community to get them on board with what we think is the best option at the end of this, whatever it turns out to be. What are we doing? Because I don't feel at the moment we've achieved that. I've been talking about beds potentially in sheltered housing or in new accommodation that could be used as beds pop up, I suppose, the phrase I'm kind of thinking of. But if we're going to have to staff those beds, why are we looking at additional accommodation when we already have accommodation? I suppose is what I would ask if I was somebody who lived in Kirkcudbright. We've got accommodations. Why are we going out looking for new housing or anything like that? If the care provision is going to be the same and the needs are the same, and we already have a place to deliver care, that's the question I would ask if I was in Kirkcudbright. So that's the question I would ask an answer for, I suppose. And what I would also like, I think, just to bear in mind is that these staff, totally different side of the argument, that these staff in all of these cottage hospitals have now been displaced for 4 years. You know, they've spent 4 years doing exactly what we ask of them. They have been bumped sometimes from pillar to post without objection the majority of the time. So whatever decision we take, can we please make a decision that's good for these staff?
Stephen wants to come in now, put it across to yourself.
Yeah, I could respond to part of that, if that's okay. And that's about looking for different places for people to be accommodated. I'm deliberately not using the word bed there. So the right care, right place is really ambitious, and David and Gary have both been really honest today about some of the timescales we've set ourselves around some of the specifics haven't been achieved. But what that strategy gives us is a vision for the future, whereby care homes as we know them today need to look very different in the future. The way we provide care needs to look very different in the future. So Gary's example around sheltered housing is, as an example, if we've got a cohort of vulnerable people, whether they have complex needs or whether they're older and frail, that live together, we've got better economies of scale. So we're looking for those opportunities on a day-to-day basis. And Nicole's referenced some work that we're doing around visioning for adult social work and social care moving forward. And that sits alongside right care, right place, but perhaps looks in a little bit more detail about the social care elements. So that's why we're looking for things that might appear opportunistic, And as we go around the table, and literacy made reference to Gary just mentioning the sheltered housing just now, or just presenting that to the table. But those are the kind of things that we're doing on an ongoing basis to see what's best. Many members of of this particular board have visited places like Fife to look how they do things differently. Lantire Life about a different reablement model and how you bring people to a central place to then get them back home. So that's why we're trying to look at different models as opposed to what we currently have, because what we currently have isn't open. And if we open it as a hospital, we've all agreed to a degree that wouldn't work for the population with the needs that we currently have. So that's why we're looking at different things as part of this process. And from a professional social work and social care perspective, it's absolutely right for us to continue to look for different solutions, because if we keep doing what we keep doing now, with the demographics that we've got, we'll be in a significant crisis within months, not just years.
Can I just come back in?
Yeah.
So what
Sorry.
you described there, I quite like that. It's something that I'm a mental health nurse, and it's been done in mental health for a long time. Are we suggesting that actually what you described there, which sounds good, will give our service users a better quality of life, and B, potentially just a better experience as a service user?
I would, if it's okay, Chair,
Yeah.
I would suggest that absolutely that would. So that's part of what we're trying to do with Right Care, Right Place. And that's why I said earlier to people, when I give my comments around the cottage hospitals, it was really difficult because I'm looking at the whole system and the things we're trying to do for Right Care, Right Place, but also in social work, social care and health environments, that is different. So it's really difficult for the voting members to make the decisions that you have to make. But we do have to think about the whole system and the significant change that we have to make for our citizens for the future.
I'm
going to come back on Vicky's point in particular. I'm going to hand over the engagement point, but in relation to the extra accommodation, I think the other part of this we mustn't forget is the best place is in your own bed. But when I talk about a modular commission, it's not just about where there's opportunities with new builds and where there's opportunities with housing schemes, but where's the opportunity to change how we commission our provider partners? Because at the moment we've got a bit, and we've got the IJB, as I say, have invested and we've seen it with flexibility in terms of payments for our provider partners to provide that care and support at home, which has increased the package pickup by 10%. And we need to shift to more of that and how we actually work with the care and support providers externally to help them sustain the market and provide that care and support at home. So whilst accommodation is key as well, I think there's also where we've got the opportunities to build upon the work we've already started and that care and support at home collaborative.
So how do we, can I just come back to how, like I said earlier on, how do we get the community on board? How do we get them on board?
Desperate.
Oh, sorry, yeah. Oh, thanks.
I was just to pick up on your point, Vicky, I think one of the things that kind of in my previous roles is community engagement, and I think community hubs are exactly that. And kind of going forward, I think that's how you get the community involved. They have a say in how that develops, how that operates, have a say in what's working and what's not. So I suppose there is an element of that to think about as well, and how going forward, that's how we stay involved.
I think you flagged off an important point. You did it under the Institute one as well, and I think it's something that we've been cognizant of previously. We have engaged with our comms officer to try and get the message out that we're having meetings, what we're going to be discussing, and we're asking that we then put a press release following that to let people know first and what our decisions are and what our plans might be. So we are making steps in that direction, but I accept that we've got more work to do, and no matter how much you put things up there, there'll be people who don't reach, or there'll be people who don't read or listen to whatever it is that we put up. It just means that we need to keep doing it, and we need to look at different ways and get our reach up there. But as I say, there are steps that we've taken. That means they're trying to do that already. Bevan, then David.
I suspect I might be going to say the same thing with David, but I guess it's like we talk about that kind of idea of change is really difficult, isn't it? And there are people kind of resistant to that and whatever. And I think what will happen is through people's lived experience, Vicky. I think as we start to deliver some of these things, if people are getting to know what that is, it becomes a bit less unknown, then that's going to start to move us forward. And I think there's only so much you can do with telling people about a thing. I think it's got to come down to how you experience that and about what difference that makes, because that's what we're hearing from members of the public now, is about what their experience has been and how, what's been good about what they've had within the cottage hospitals, where things are more difficult that they're in some instances seeing because of the challenges that we're facing and around where that is. So I personally feel that that kind of experience that people are going to have, as Stephen mentioned, it should be improved going forward. And I think that's where we'll start. And I don't think that's going to happen overnight. I think that's going to take a bit of time. It's not just for people who use the services either. I think we need to remember that that's for the staff groups too. We think about where we've been with the changes around home teams and how long that's taken to get in, and things are really starting to see some of that difference in similar with our independent partners. So it's unfortunate, I suppose, Chair, that the IJB's got to be the ones that are making the decision about where that is, but you can only do that with in the hope that as people experience it, and the intention is to make things better, so therefore people then start to come with us, I suppose.
Did you want to add anything to that, David?
A couple of things. So I agree entirely with what I've just said, and I suppose reflecting on previous experience within another cold area from the past, the best way to get the public on board with change is that word of mouth and the positive experiences they have. But I think to supplement and complement that, it goes back to what I said earlier on, we need to have a really proactive, detailed comms plan about implementation. I think we do really well around planning change, and we need to carry the lessons from that into how we implement change and have that detailed comms piece there. The bit of maybe challenge for everyone is around the challenge that she just said in terms of how difficult it is for the IJB to make decisions. That's why the IJB is here. Your key purpose is to assess local need and to make strategic commissioning decisions as to how best to meet that local need. So I think it is your raison d'etre, and I think it's really important that IJB rises to that challenge.
No, quite clear on that. Yep. Anyone else? Ian?
So I'm stuff that came up this morning. Assurance around the home care, the care home, sorry, being fit for purpose. That was by Jeff. There's some assurance in regards to that. Each area is unique. It could be as well. And one of the other comments was made was that is this model of care stroke level of transformation, is it could be ready for it? Maybe we could have some comments in regards to that. You could apply that to all four, I suppose. And see, agree entirely with what's been said in regards to Edgar Mark in particular. Is emphasising institutionalised stroke acute care, the detrimental effect that has on the patient stroke service user. But I'm thinking back to True History and Darity. So people with, in particular, and I should have asked this with the last year as well, I should have made this point even, but to get the comments. So people who have got even later stages of dementia and such like, so the impact. So I would say for people who get to an age that absolutely right, are buying right into that part that they should be in their own homeless setting, ideally their own home, and I've supported it all the way through strategic plan and otherwise. But when it gets to that type of clientele, is it the same for them, do you think?
Absolutely. It's probably even more important in our patients with dementia are cared for in that familiar, personalised environment where the setting is set in a dementia-friendly way, and that comes down to things like the colours of the walls, etc., that have to be specifically coloured for dementia patients in order for them to be able to recognise and be familiar with the settings. So again, it comes back to that. We know that where patients are cared for in their home or in that homely setting, they are more likely to get that longevity of care and that quality of care that allows them to live longer, healthier lifestyles. And it's very difficult, to give you any good cases for saying putting a patient back into an inpatient bed is advantageous to them within that setting. So, I think I've got real clarity around that in that professional space. Our want is for our patients to be cared for within that homely setting. For those dementia patients, we now have care homes, they have dementia-friendly rooms, etc., that allow those patients to be refamiliarised within those settings and have the best quality of life that they can have.
Thank you. So two other points if you don't mind, just if you can answer them, that was only about the assurance of the care homes. And they was mentioned in regards to are they fit for purpose. Now we're moving forward. Two of them in particular, not they need to be named by any means, but what was my other point? I just is completely ready for this level of transformation for the model of care. If that can be answered.
Yeah, Mark.
So I can certainly pick up the question around the governance and the assurance frameworks of the care homes within the Dumfries and Galloway region. As I alluded to this morning, we have very close governance pathways and oversight of care homes within our area, where we support and assure and improve the care within those settings. Close collaboration with the care inspectorate, close collaboration with colleagues like Scottish Care to ensure that the care that's delivered in those settings is as high quality as it can be. Now, of course, there are times when there are concerns with quality of care, as there is within any ward setting or within any other settings, that there's always lapses in standards of quality, and we've got really robust processes that we keep an oversight of to go into those settings to support the staff to reach the standards required. So from that perspective, we have 31 care homes within our region. We have really good scrutiny and oversight of those homes, and when homes have quality care issues, we are closely monitoring, assuring and supporting them to deliver those high standards. So I'll put that in.
Thanks, Mark. I'm going to come to Steve and then I'll ask you if you're ready for it.
Just to add to Mark's comments about standards in care homes, clearly the care inspectorate has the primary responsibility to register and to inspect those care homes. But from a commissioner's perspective, we've got good oversight, and we also have a rapid care home support team where we put targeted support in. And currently we are putting significant targeted support into the two that were referenced earlier today because of where they are. But we also have to be really realistic about the theory review, the independent care review of adult social care that was referenced by Steph earlier today. And Shirley and his colleagues found that the standard of care in care homes across Scotland was very variable and not always positive. And that's no different in Dumfries and Galloway. We have to be open and honest about that. And that's why I made reference earlier to looking at different things. So care homes of the future should not look like what care homes of the present look like. I've made reference in another forum about care villages, extra care housing, digital solutions, etc. And we've got to look at the whole combination of those things. And that's why, it's really important to be mindful of that. So we do target, we do scrutinise, we do have a degree of governance, although it doesn't sit with us as a board or you as a board. But we do put the support in where we need to, but we think differently about what the care we provide locally looks like and how it needs to change. And I think the tough decisions that you have to make today are part of that process.
Beth?
I've been given quite an impossible question, so thank you. So I'm going to try my best to answer this. So I suppose what I'm going to flip that round and say is Kirkcudbright ready? The Health and Social Care Partnership is in a state of readiness like never before. And if I refer to the slide about the Right Care, Right Place programme and that wider programme of strands of services and supports that are now in place that weren't there pre-COVID, like your home teams, you've got your prevention, early intervention, prevention pathways, you've still got your cottage hospitals and specialist rehab in your locality, you've got discharge to assess, you've got care support at home and increase in package uptake, you've got rapid response, we've got hospital at home, and we've got the residential care and the care pathways, which we are working closely with the care homes in relation to changing those pathways into care homes, because we know we need to make sure that the people are being appropriately placed in the right care home as well, with that skill mix within that care home setting. And there's the longer term piece of the medium term and longer term about a care home strategy and what that needs to look like. So I cannot answer on behalf of the community of Kirkcudbright whether they're ready, but I think partnership is in a state of readiness to deliver that care and support closer to home to support the concept of that option 3 in that community health and social care.
Thanks, I just think it's important, I think Ben touched on it earlier as well in regards to Colm's question that Vicky brings up. We have got Rod Edgar and his team, I think that's very important to recognise that as well, but the fact that it's how we deliver the service, and that's what's got to be the game changer here. If this service delivered, depending on the decision that we make, that's going to be the best. That's only a point I probably should pick up on rather than the question, but no, thanks.
Well, Chrissy.
Can I ask what the impact will be on the workforce in the meantime whilst we can't procure those 5 beds? So what impact will be on the home teams? If families decide that they want palliative care locally and we can't procure those beds, what impact could that potentially have on the workforce that we have already in providing that palliative care service, please?
So in terms of the general workforce impact, option 3 is deliverable from an operational perspective in terms of the workforce that we already have that's within our home teams and other areas to support that. Are you asking are you asking about specifics in terms of?
I'm asking if we can't, palliative care, so if we can't get the 5 provisions within care homes, so we don't have actual spaces outside of the home for people to go for palliative care within the community, what impact will that have on the workforce? How will that sort of like be mitigated as a challenge?
So I would argue, Chris, that that's exactly where we are just now. So those beds are not in place just now, and those home teams, as Mark has already said, actively supporting people with palliative care needs and end of life needs at home just now. So I would say, in the absence of those 5 beds, there's no adverse impact onto the home teams. But as those beds come on stream, that gives the home teams another tool in the toolkit to use as appropriate based on those individuals' needs and preferences. So I think it actually bringing them on stream helps and supplements the work of the home teams, but the home teams are already coping with that group, right?
For me, one of the most memorable comments made by the Kirkcudbright presentation this morning was about the financial mismanagement. So I'd be interested to understand if we've got an answer to the question that was proposed by Jeff, where he said that, let me just see, are they paying for poor financial management, and is it ethical and fair? Katie, can you assist us?
Thank you for that one. Quite rightly, you would imagine I would dispute that where we've got to financially is on the basis of poor financial management. We don't ring fence budgets for specific geographical areas. That's not the way that we approach things. And I think in terms of the specifics around why we need to invest to get the beds up and running, it is on the basis that we did freeze the budgets at the point in time that we froze the beds during COVID. And so bringing them back online requires investment to do that, both in terms of, I think Steph talked before about things like, say, the staffing legislation, the fact that we've now got different grading for healthcare support workers, band 2 to 3. And also, I think you mentioned, Chair, the fact that we've seen considerable kind of inflationary pressures across services, and all of those kind of things are driving the real financial pressures that we're seeing across the entirety of the partnership. And I would say in terms of the specific financials for this case, it probably shows the diseconomics of having just 2 beds as a model. And I think Steph quite eloquently talked about the staffing for those beds and the fact that you have to have a qualified and a healthcare support worker on at the same time, and how that builds in, by default around about, I think it was 11, he said, in terms of the numbers to kind of keep that rota up, which is about a cost of £1 million, which is where if you're only having 2 beds, it's quite an expensive cost per bed. So I don't know that I can specifically refute the claims of the individuals this morning, but I do acknowledge that we have seen increased costs of all of our services, and that's one of the drivers in terms of our kind of current financial deficit, Chair.
Thank you, Linda.
Yeah. I'm a wee bit worried about taking 1 or 2 off the cuff remarks from somebody who presented this morning. about financial mismanagement because we've no evidence of it.
And that's why the question was asked.
Yeah, well,
You know,
exactly,
because
and I think,
ultimately, this meeting's been made available to public, including the presentations from People's Corner. And I think it's only right that we rebut some of the things that have been put forward. And really what I'm doing there is allowing Katie the opportunity to do that.
well, can I just finish? Yeah, because what I'm saying here is that there's an absence of evidence, and really, the person who said it should know better, because he's appeared at many tribunals and things like that in the past, in his old role. If he's going to make a statement like that, he also made a statement about spaghetti hoops.
Did.
Right, you know, I mean, it's totally inappropriate. I didn't say it at the time, but if we're going to kind of raise that kind of thing here, where does this end? Right, because I would expect people who came like I see the two guys are here from Moffat still, came very factual, told us everything. We went through the whole lot very professionally, and that's where it was. I'm disappointed in Jeff Dean, the way he puts stuff across. I'll be open with
I don't
that.
think we should personalise it, Andy.
I'm not personalising it, but no, it was him. Well, because everybody who heard it knows who it was. So it is personal because he's the one who made the statements. Right? Whether that was on behalf of his group or not, I don't know. Right? But I'm just worried about actually where we're heading with this, because we need to stick to the facts of the situation here, and let's move on with the business. With all due respect, Chair.
Okay, no, like, noted, thank you. Anyone else? Okay. What would just lastly like to say, and I've lost my page and that's about this. But I think it was highlighted earlier, I think, either by Val or by Gracie, you know, that during the day of assessment, that 52% of people who were in cottage hospitals medically had no need to be there. And there was another comment about 72%, and I find that all.
That we need to share before COVID and 50% in September 2024.
That's right. I found it now that you've said that. Yeah, data from DFK audits, November 22, 72% of people could have been better supported in alternative settings. And then goes on to say that in 2024, 52% of cottage hospitals meeting. Never more than 52% of the people in cottage hospitals meeting the criteria for being there. So I think there's a case being made for option 3 for me, as far as I can see. But if there's no more questions, I'll pass over to Claire to give us the views of SPG.
Thanks, Chair. So the strategic planners have noted that the preferred option of option 3 didn't reflect the public consultation response. We noted, or we raised concern around the provision of flexible beds at a local level, and noted and we're given reassurance around the commitment to local care for local people, protecting bed capacity in local areas and using facilities that are closest to home. The group agreed that this approach should be embedded as a priority, and on that basis, the strategic planning group supported the recommendation of option.
Okay, so we're at the point again where we're asking, do we have sufficient information in front of us to make a decision today? Right, no dissenting voices there. So that being the case, I think we've had a robust conversation and discussion. We're looking at next year and now what's appropriate. And I'll just ask that can we go around our group and say if we're happy to go with the recommendation of option 3. Okay.
I am happy to go with the option 3, but and I think probably what I missed in Newton Stewart one is what I think we need to do is about the cons. And I think going forward, you know, somebody mentioned that this is kind of the beginning, and it needs to be the beginning. And I think what we need to do going forward from a comms perspective is show Kirkcudbright a service that they can get excited about. They want to see, and because I love things like this. I get excited about anything about making lives better for older people because I'm an older people's nurse. But we need to show Kirkcudbright. And if we can do that, if that's the commitment that we can make, then yes, I would support option 3.
that sounds like a conditional support, whereas what I'm asking you for is, do you support option 3 or not?
If we could, yes,
Yeah.
yes, I support.
And what I would also say in relation to your comments, it's not just about older people.
No, it's not just about older people, you're right, but the majority of people who would be in these cottage hospital beds will be older adults.
And the service that we're looking at providing is for the whole community.
Absolutely.
Alice?
Option 3.
No?
Option 3.
Ken? Right. Option 3, Ian?
Recommendations.
Chrissy?
Sorry, I need to go with the hybrid. I don't think that we've cured the beds, and I don't think that the care homes is stable enough at this point.
Okay.
Option 3.
Andy?
I just say that the communication and marketing plan is what's absolutely Vicky's talking about, is the $64,000 question. Is it's not just about communication, it's about how do we market it, how do we sell it to the public, rather than just tell them about things.
Kirsty, you captured that?
Yes, we have.
Okay, so can we now? So can we confirm the preferred option for Kirkcudbright Hospital is option 3, which is a community and social hub? And can we endorse directions specified to be issued to the NHS board, please? Okay, done. Okay, thank you. Moving on to item number 9, which is presentation of findings for Right Care, Right Place programme for Thornhill Cottage Hospital. Can I confirm, members, that the third set of findings will relate to the future use of Thornhill Cottage Hospital, and advise members that in their pack, they received a pack for the site containing detailed analysis of 6 options consulted on for the site, plus the hybrid model suggested by people at the local area, and the additional option proposed by Dumfries and Galloway Council following consultation. Can I confirm that members are being asked to confirm that the process to date and associated outputs are consistent with the requirements of the Direction 2302C to develop a way forward for the use of the cottage hospital sites, and to confirm it is assured that the process of engagement and participation in the consultation process itself have been conducted appropriately and in a way that is proportionate to subject matter and in line with the planning with people guidance. Also, to approve the recommendation to progress option 3, Community Health and Social Care Hub, and to issue the attached draft direction to establish a Community Health and Social Care Hub in Thornhill Cottage Hospital, including allocating a budget to deliver it. I should say that from NHS Health Improvement Scotland have suggested that we should make, in reviewing the analysis, we should, 1, analyse and consider the feedback from people in communities, recognising that although the options for each hospital were considered as part of one public consultation exercise, there are different nuances and contexts for each individual cottage hospital location, and therefore the decision that IJB makes for each may be different. A respondent to a phone interview said, there are 4 hospitals involved in the consultation. They are not all the same, not one size fits all. And I would ask you again to bear that in mind as we go forward. 2, to explain how the hybrid model, which is a combination of options 3 and 4, put forward during the option appraisal will be considered alongside the consultation feedback. And again, I would ask you to take that into consideration in our deliberations. 3, consider how we can address concerns raised about capacity for people to receive inpatient care at Dumfries and Galloway Royal Infirmary and the remaining cottage hospitals. An attendee at the Kirkcudbright in-person event observed there are people in DGRI who don't need to be there, i.e. DGRI, but there's nowhere else for them to go. And similar concerns were also raised in other in-person events. At that point, I'd like to turn to Nicole again to ask her if she can advise us and update us in relation to the delayed discharge issues.
Certainly, Chair, and as I've covered earlier today, because I think the position's seen for all sites in terms of this matter. However, what I would be advising is that these beds wouldn't have a benefit to delayed discharges due to the fact that if somebody shouldn't be medically in a hospital, moving them to another hospital bed as opposed to supporting them to return home is not in their best physical, mental or wellbeing interests. What I would say is we have been working very thoroughly over the last few months to improve our delayed discharge position, working with the Scottish Government and other partnerships across Scotland, where our average delays for standard delays is where we benchmark poorly historically since COVID, with the average number of delays being between 100 and 120. As of today, we are in the low 70s in terms of delayed discharges, and that's due to the phenomenal amount of work that's happened across the Health and Social Care Partnership with teams. And I commend them for the work that they have done at pace, and that has been round about 3 short-term elements of work and 1 longer-term element of work. And just to highlight that again for due diligence, just to make sure that people listening, particularly round about Thornhill Hospital, that has been round about the delay discharge without delay principles within hospital, meaning that we are planning with people and their families and support discharge planning from the minute that they are admitted to hospital, which is having a huge amount of benefit to length of stay for not only delayed discharge patients, but also the process of not becoming delayed in the first place. The second piece of work has been round about our care homes and reviewing the choice guidance and how that is applied and how we use interim placements. And we have procured an additional 10 beds in our care home, which is additional to the right care, right place beds, with 5 of those coming on stream in October and another 5 in November, which has hugely improved our pathway for care home. The other, and probably one of the most significant process changes, is the implementation of discharge to assess, which is in line with our hospital home Scottish Government approach, where the evidence and our professional colleagues can support that. The evidence is that people recover better in a homely setting when surrounded with familiarity. And we've been working with providers in terms of increasing capacity to support that rapid discharge from hospital. And as Steph has highlighted earlier, we have seen a 10% increase in the care at home provision. We're also absolutely embracing technology and how we use technology to support that care at home provision, so that that valuable resource for hands-on care is protected for those that require it, and therefore looking at a blended approach. It's not that we would be using that and that alone. And then the fourth piece of work, which is the longer term, is that hospital at home frailty model, working with the clinical team in acute to do that outreach and supporting people at home with that support, along with technology that does remote monitoring and supports us to support people at home as opposed to bringing them into hospital where we know that they can be subject to harm. So just in conclusion, I don't believe that any additional inpatient beds would benefit delayed discharges, and in fact I think it would increase the number of discharges, given that the staff would potentially have to be supporting the inpatient beds, and we would potentially have social admission because we wouldn't have the staff available in the community, and a social admission is a delayed discharge from the point of admission, Chair.
Okay, thanks for that, Nicole. Just turn to our professional advisors, see if they have any further information or advice that they want to offer in relation to appropriateness of reopening inpatient beds.
Yeah, thanks, Chair. So I'll just come in just to discuss the areas we've discussed this morning, but in relation to Thornhill, I just wanted to again outline the disadvantages of stepping patients who are fit for discharge down into a cottage hospital setting. While they're awaiting discharge back into that setting, evidence tells us that the patients lose independence and functionality. The long stays in hospital settings, even in cottage hospitals, often lead to deconditioning, loss of muscle strength and independence. A 2021 study found that the extended hospital stays delayed the recovery of the activities of daily living, which are skills that are critical for patients caring for themselves at home. We know there's a psychological impact where patients' anxiety, depression and feelings of dependency increase through being kept within a hospital setting when they're fit to go home. Studies show that patients that are kept as delayed discharges within an inpatient bed are likely to become institutionalised, leading to that reduced motivation and confidence to actually get themselves back into that homely setting. We know even within a smaller cottage hospital setting, there's an increased risk of exposure to hospital-associated and acquired infection. And a 2022 NHS England study on the palliative and end-of-life framework confirmed that patients awaiting discharge face a higher risk of urinary tract infections, respiratory infections, which further delay their integration back into community life. And it also, the prolonged stays disrupt the social integration, back into those community settings as well. The evidence absolutely is suggestive that keeping fit for discharge patients in Scottish hospitals contradicts patient-centred principles and may hinder that longer-term recovery, underscoring the real need to prioritise that timely only discharge with the appropriate patient support.
Okay, thanks, Mark. Anyone else? Okay, so we've further been asked to ensure that additional impacts for each locality identified through the option appraisal and consultation process are included in the updated impact assessments and are fully considered throughout the decision-making implementation process. If I could just pass across to Viv and Steph now to give us a bit of an input on that, please.
Thanks, Chair. Yes, a good practice would be that the quality impact assessments would change and evolve over time as new impacts become known. We have updated the impact assessment in relation to the recommendations, the recommended option 3, specifically, and mitigating actions added. And we would expect to see that updated and continue to be updated through implementation as we go forward, and for any other developments alongside that.
Thank you. So we're also asked to demonstrate how we've taken into account through the Fair of Scotland duty the concerns that people have raised in relation to the challenges of accessing services due to limited public transport, travel and distance and costs, and we've had those conversations already. Also asked to recognise the concerns expressed by some people during the consultation around perceived erosion of local services and consider how these concerns may be addressed. And what I say is that as a board, if we were to go with the recommendation of option 3, it will mean that an increased range of outpatient services and outpatient treatments in the first instance, with a commitment to look at wider service provision in the future development in the area. Also to acknowledge that during the consultation, people have consistently expressed the importance and high value attached to the inpatient beds in their local communities. And I think that we've seen representations of that throughout this day, especially from the community inputs. Also, the feedback to communities on each of the decisions reached and how the IJB conscientiously considers people's views and takes into account financial considerations and how they've impacted on the decision-making process and how the issues identified, for example, in relation to travel and access may be addressed moving forward. And again, we have looked at that through the direction. If the proposals are approved, then we recommend that the following areas are considered during implementation. That we continue to co-design solutions with agreed timescales with people, communities and partners to help mitigate adverse impacts identified through the consultation responses and the impact assessments in Fair of Scotland duty. For example, transport and access, as mentioned previously. Also, that we recognise that the commissioning process ran in parallel with the public consultation. This may have resulted in some changes to how the intermediate care model will be implemented, and if the changes are substantially different, there may be a need to consider further communications and engagement with affected stakeholders. We've had quite lengthy conversations about how we communicate with our communities and let them know. Also, all stakeholders are offered the opportunity to be meaningfully involved in the implementation of IJB's decisions, and I'm sure that we're already given that commitment, but we should reinforce that. Now going to pass to Viv and Steph gives a presentation in relation to Thornhill Community Hospital.
Thank you, Chair. Have to start off, I'm sorry, with an apology just for a couple of typos, errors that have not been picked up through our proofreading. And really just by way of explanation, just I suppose there's a lot of papers with a lot of input from lots of people here, and I think when you're very close to it, it's very difficult to not go that kind of word blind around that. Also, there are similarities between the papers, so what we've done is we've updated and changed part of it is that we've obviously copied things across. So sincere apologies, there are 2 errors in the paper for Thornhill. The first one is on page 37, where it refers to Stewart Hospital, whereas of course that should be for Thornhill, and within the direction on page 51, there is a reference to the markers, where that should be mid and upper Nithsdale. So apologies for those errors in your papers. Okay, where I want to start really was just to remind us that the reason for all of this work was as a result of our direction from Inflation Joint Board in September 2023. give appropriate consideration to the level of engagement and consultation required to work with communities to develop a way forward for the use of cottage hospital sites where there are suspended inpatient services. That full direction is in section 1.4 on page 9 of your paper. In order to do that, we've worked with the communities to develop different options for Thornhill community, and that resulted in 6 options being taken across to IJB. And in March of this year, there was approval that those should go forward for option appraisal and further consultation. And those are listed within section 3.4 on page 12. And what I will say is that the options were around status quo plus, community health and social care hub, the re-establishment of inpatient services, which for Thornhill, we're looking at the opening of 8 beds, community ownership and closing of the site. During the option appraisal process, a hybrid model emerged, and section 3.5, appendix 5 of your paper had a full description of this. And it wasn't possible to include that in the option appraisal. It has been subject to the other elements of the assessment. And just to note that for Thornhill Hospital, the proposal was that that should be for 4 beds. As part of the formal response to consultations, Dumfries and Galloway Council colleagues proposed a slightly different hybrid stroke blended model. And section 12, page 36 provides more detail on this. And that has been subject to some of the assessment, obviously not able to do the option appraisal for the consultation part. But the main difference there is that the suggestion was for 2 palliative care beds and 2 respite beds within the site. We've undertaken to assess 6 different elements for each of the 6 options and hybrid model, and the 4 obviously for the Dumfries and Galloway proposal, and these are described on page 14. We've got the option appraisal is one part of that, and that was undertaken by people who access services, people who deliver the service, and people who manage the service. We've got the consultation results analysis, and in relation to Thornhill, that relates to 389 surveys. 49 of those were from staff, the rest from obviously members of the public. And what then the next part was around financial appraisal, and that was put together by our finance colleagues for us, and there's information within the paper around that. Similarly with the workforce appraisal, and that was developed by the operational team and professional advisors within that team, and then support from the employee director and workforce director of NHS Dumfries and Galloway. To finalise that, professional advisors to the integration joint board are obviously here, chair, they were able to talk to their views, but we've included in the paper along with the operational management team's assessment of deliverability. What we've done within the paper, the cover paper, is group that all by option, and within your appendices, those are given by the element, so that, for example, if you wanted to have a look at the financial appraisal for all of the different options, you would just look at the appendix for that rather than through the main first of the paper. What we've undertaken to do, really with the intention of consistency of approach and to try and be as objective as we possibly can, is undertake to establish some criteria for a red, amber, green rating across all of the 6 elements, and those are described, that criteria is described for you within your paper as well, and I'm very happy to take any questions about that if anyone wants any further clarification around it, but I'll take you through what the results are.
Okay, so through all the 6 elements of assessment, it's quite clear that options 1, 2, 5 and 6 are not favoured. Option 4 favoured well with the stakeholders and options appraisal. However, this is an unaffordable and sustainable model, and it's not deliverable. It also does not reflect the ambition of the Right Care, Right Place transformation programme, local, national strategic direction. The hybrid model for 4 beds at Thornhill Hospital also rated well with stakeholders, and it is deliverable but with some risk. Caveat to that is that risk is likely to increase due to the workforce challenges both in the short and medium term, and therefore this model could become unsustainable very quickly. The high costs for the hospital beds mean that this model is not delivering best value and presents significant risk. There is a high likelihood that this model would have a detrimental impact in other areas of the system, particularly our ability to provide care and support for people at home through our home teams model, introduction of flexible beds, and our impact on acute services. It was also not favoured by professional advisors in terms of quality and safety. In terms of the recommendation and rationale, the recommendation made today is that through the assessment of the 6 options, the hybrid model and the Dumfries and Galloway Council proposal, it's been identified that option 3 for a community health and social care hub is the recommended option. This is based on the following. So this offers greatest benefit overall. It aligns with the IJB model of care and strategic commissioning intentions and supports the ongoing transformation of community services. There are significant recurrent savings attached of £684,000 per annum to contribute to the financial recovery plan. It offers best value with £50,000 per annum for a flexible bed compared with £182,000 for a hospital inpatient bed, or indeed £269,000 for the hybrid model in Dumfries and Galloway Council proposal. This can be delivered and it is sustainable from a workforce and operational perspective. Appreciate that whilst the public views that option 3 does not meet their needs for bed-based care, however, there are flexible intermediate care beds within the locality area which has served the population well to date. Shifting the balance of care from beds to home-based services is the direction of travel and fundamental to the community transformation work ongoing since 2021. Professional advisors to the IJB have expressed the belief that option 3 offers safe, effective care and with every need, while having potential to improve public health and tackling inequalities. A community health and social care hub has the potential to grow and develop in line with the needs of the community, digital capability and future innovations as they arise. There will be opportunities to expand the range of day treatments, outpatient appointments, early intervention and preventative approaches, integrated care and support, extending the home teams to combine statutory, independent and third sector, mental health supports, as well as new practices such as holistic, person-centred styles of care such as a day hospice. The unique factor for Thornhill in relation to option 3 is that the GP practice is actually on the campus site alongside the hub setting, so this would lend itself to joint working opportunities with the practice multidisciplinary team and enhanced contacts and joint working with a range of community services. Subject to IJB agreement, plans for further development of services within the Community Health and Social Care Hub will be explored with teams and local people before bringing forward fully costed proposals for consideration and a strategic commissioning decision. Thank you for your attention today. We're happy to have any questions that you may have. Thank you.
Along with your professional advisors, do you get anything like that or contribute to that?
Thanks very much for that presentation. I think just reflecting on the presentation we had from the Community Council members today, were clearly, they were very supportive of a hybrid option. But I think it sounded as real acknowledgement in the community about the need to evolve the facility in Thornhill, but they did feel that a hybrid model was what they preferred. But my preferred option, which I outlined in the paper, was the community hub option, option 3. And I still do believe that that is the best use of resources, given that actually there's a wider range of people who could access services from that site. And so that still remains my preferred option. I think one of the real challenges that we have is, particularly like as a strategic board, and from a population perspective, we've got a limited amount of resources and we need to use those to get the maximum that we can from that. It's the best value assessment is really important. So acknowledge the difficult decision that the IJB has to make, and acknowledge the preference of the local community, but I think there's a real opportunity to develop that model, particularly within that community hub that could support a greater number of people in that local area.
Yeah, thanks, Bob. Anyone else?
Lucy.
Yes, I know I have said this along previous occasions for the previous discussions we had had. I think it's important to highlight the need for us to be fit for the future and to ensure that we are sustainable and that we are commissioning the services that we need, acknowledging the challenges of the present, and acknowledging the needs and desires and wants of our communities. In terms of how best to utilize the resources that we have, I support option 3 as a way forward for all the arguments that we have heard. But for me, it's really important that as a strategic board, non-voting member, and give my best advice to the voting members of this board around what is needed for the future. And for that, we need to ensure that the limited resource that we have is best used, and shifting the balance of care to the community is really the way forward. And with this, we are doing what we have said for many years and not really fully done around thinking about those community hubs and thinking more about community services rather than key services. So for that reason, hopefully from it. Thank you.
Okay.
Yeah, this is quite repetitive, isn't it? So I will keep it brief, because I'm really getting for colleagues that it's that model of modern health and social care, which is really around limited time in a hospital bed and getting the home as quickly as possible. We know is the right thing to do. And we have a limited resource both in workforce and finance. And for me, the way to utilise that space that will service the community best is through option 3. Putting our resource both in people and money into opening beds will provide, support to a much smaller group of that community. So option 3 definitely is my favourite option because of that. I feel like I've gone over this several times, so I'll leave it there.
Anyone? Stephen?
Yeah, thanks, Chair. And again, like Ken, it's difficult as the day goes on and we get time, but we absolutely have to give, credence to Thornhill as a population as well as the others that we considered. So my perspective from a social work and social care point of view is that we should not have inpatient beds as described by Mark. The impacts are quite significant. We have to do things differently, and I think option 3 gives us a starting point to do things differently by bringing other health initially and social care services into the area. I think we have to listen to what the local community want as we move forward, and we don't always give people what they want, but we have to look at what they need. And I do believe that option 3 gives us that possibility. It is disappointing to hear from the community that the care home in Thornhill doesn't want to engage in relation to intermediate beds. But we have to look at different solutions around that. And Gary's, alluded to, housing, etc., and doing things differently as we move forward. And I absolutely support that as a view. And I think option 3, as presented to us today, gives us a starting point. But it is a starting point. We have to think about the whole right care, right place, the whole system, and the changes we have to make as we move forward. So I do believe that option 3 is the starting point for us.
Thanks for that, Stephen. Open to members for questions. Greg?
Just on the part we talked about care homes, and that was obviously brought up by the community council this morning. Just could ask for clarification from someone. When we're talking about in the reports, and we've got the words pending in terms of that contract status, and we've got the words draft. What do those actually? What's the distinction between both of them in terms of timescales for those beds to come online?
Well, for looking at Staley and for Thornhill area, we've got an agreement now with Queensbury Park Care Home. So that's in place. So those beds are immediately available. I think the other issue, and I know it was an issue raised by the group this morning, in an ideal world, we would have commissioned a set number of beds in Upper Queensbury and a number of beds in the Thornhill area in Bradley Park. Now, I don't think we need to keep the door completely shut, because the way we commission these beds initially is for 12 months. Now, I think the intention is to be longer term. And who knows, there may be a change at Bradley. I just want to assure people that, our preference would have been, from an office perspective, is that we have got the 7 flexible beds in the Upper Nitsdale area. but we haven't got the balance right. And ideally, we want to work towards a situation where we've got the in the Thornhill area as well. And that may be possible. It won't be possible straight away, but it could be possible over the next year or so.
Other question. Well, when we're thinking about the financial appraisal, and use the word the recurring savings, I guess. I think we need to be careful with that one, because what we've said with something like option 3, if that's the decision, that was something that could grow and evolve as with the community's input, with IJB input and etc. to offer services that add benefit to the maximum amount of people. So that recurring saving isn't something that's fixed. That's what I guess I'm asking. What we're talking about there. So recurring based on a baseline and the financial appraisal, but going forward, the services that are offered will evolve, and that will mean the financial impact of that will change as well. Yeah. Who feels best?
So those savings will be taken out as a saving, and one of the things that we be clear in terms of the financial recovery programme is to recognise savings and cost pressures and investments in kind of different strands. So if there are any changes that require significant investment as part of that development, we will need to look to resource to support that. That being said, and it's maybe one that Steph can comment on, there's lots of changes that we know that we can make, which is around shifting where we do things rather than, and I think the specific thing for me, with my other hat on, NHS board hat on, is we are developing infrastructure plans in terms of the capital investment required, because I think that's going to be one of the kind of the key areas to get the maximum benefit out of the hubs. So, some of the technology that we need and some of the changes, and we're already kind of looking at that as part of the planning for next year. So I think focusing just on the recurring revenue cost and looking at other opportunities is something that we absolutely need to do.
Any other questions from members? Okay, Kristen.
It's not the same one, because obviously you have procured 7 beds. Slightly different on this one. They did say this morning that the beds haven't come to fruition in their area. What is the sort of because you have procured them, you can say where they are, I'm assuming. So what is the timescale of distance for travelling for people to get to these care home beds that we have procured, please?
Well, it's in.
Can I ask you to speak up as well, please, Gary, because we're really struggling with this thing, that I am.
Okay, it's about half an hour. It depends, assume people have got access to their own vehicle, it'll be half an hour.
And are there any transport links if they don't have access to a vehicle to get to these beds? For visiting people in the life care?
So it's on a main bus route.
Okay,
Thank you.
Thank you.
Okay, that's me. Any other questions?
Small one, if it's on the report itself, it's part 11 of the direction, which is, this is transformational stuff. I can make assumptions what committee that'll go to with regards to the performance management, that is. I just wonder what committee will that be? Will that just involve the transformation and innovation features committee? Is what I was thinking that.
It will be a performance quality finance committee. That's where we monitor all our direction.
Yeah, thank you. Okay, sorry.
Just one final point. I made this for Stuart as well. I think what's key as well as we go forward, if that's the decision to go forward with that direction, is how we will monitor any detriments to the wider supported community, the catchment area, whatever we would call it. Obviously within Thornhill, and we talk about vaccines, but within that wider region, up on this deal, there's for example, if we just look at vaccines, there's pop-in centres and things for vaccines. So it would be about if there was any change to the services that are offered kind of wider, if those were centralised to Thornhill, it would be just get reassurance that any impact such as those decisions would be looked at and we would assess those down the line.
Good.
Yeah, thanks. Yeah, that's absolutely part of our planning practice, Greg, is to make sure that we're looking at the impact across, there's a range of impact tools now, isn't there, with the quality impact, public health, and tackling inequalities, impact assessment, and also the climate and environmental. I've probably got that the wrong way around for that one, but there are a range of assessment tools that take part of that, and that would be pretty standard within what we're doing with any kind of service change.
Oh, thank you. It's actually a general point about all of the whole of Dumfries and Galloway. And it's just about looking at palliative care centres from the third party sector. Like, is that an option that we could look at? I know it's not necessarily going to resolve anything, perhaps in this instance, because there's only potentially going to be one. If there is, and it's still going to be travelling. But I sometimes wonder whether being in a care home for perhaps a younger person who's receiving end of life care or palliative care is the right place. And so it would be really good if we could have a really decent facility for people to go to. Just a question. Thank you.
So really interestingly, Emma, was there's been a recent publication of a new palliative care strategy for Scotland. And I think our local palliative care plan is now probably about 4 years since we put that together. So we're already looking at what is in that, how can we refresh all of that, and of course all of the development that Stephanie's spoken about within community health and social care directorate, what we've heard around the potential for these hubs and the potential for sort of day hospice and things like that. All of these things will need to be taken account of. And I suppose that's just a really good reflection. Thanks for the question about how things evolve and change over time, and that it'll be really important that we keep up with those and take up any opportunity, all the while, of course, making sure that we're working with our communities and other stakeholders. And I think that there are some great opportunities for us to work with our third sector and our independent sector partners around some of that.
Yeah, thank you.
Alan, do you want to make any comment on anything there?
Not other than I've already mentioned. I think the proposals, as I've mentioned in other options as well, I think do present significant opportunities for better partnership working. To be honest, I think the third sector can play a significant role, and alongside the independent sector, there's something we could redesign rather than us just being the sector being the service provider. There's something we could probably do much better together. So absolute support Viv's comments, and we're already in early discussions about how we might do that in a number of areas.
Thank you. Vicky?
So Thornhill Hospital was one of the small hospitals the small hospital who provided the most staff to Ward 1 when it opened at Mountain Hall. And I think of the group that we've got left there, more of them are Thornhill Hospital than anywhere else. And I just wanted to ask, are we confident that we can absorb those individuals, because we've already said that Ward 1 is closing? And those Thornhill staff obviously are going to be surplus to requirements for Ward 1. And what we're saying is we don't need, or what we're proposing is not needing them back into Thornhill Hospital as a team. So are we confident that we've got enough work to absorb those members of staff back into the mid and upper Nithsdale team? Doing some.
Thank you, Vicky. So in relation to Thornhill Hospital, the current number of staff who are deployed is 13. 6 of them are in home teams and 6 are in another community hospital. So that could be the Mountain Hall cohort.
Yeah.
Within Thornhill itself, within the home teams, they are, as I say, there's vacancies being covered. So there's opportunities there for permanent posts. The redeployment, we will have to look at obviously the workforce planning behind that redeployment with all of the staff involved in this, not just Thornhill, in terms of what options are open to them. However, what I can say at this point, in this specific day, because you appreciate some moving feast in terms of staff and in terms of movement, that there is a confidence level in terms of permanent opportunities being available for registered nurses and healthcare support workers. Either that within the vacancies in home teams, or where we know there are considerable vacancies across other hospital sites in terms of registrants.
Okay, thank you.
Can I just ask on the back of all of that, we've procured seven beds, and so that's on a contract for 12 months, am I right in saying that? Yeah.
Yeah, initially.
And so after that 12 months, what's to say that these private providers don't say, well, we want X more amount of money for the next 24 months, or you're not having the beds, and then we're absolutely stuck. And where do we lie with the palliative care for young people? Because Emma's raised a really, really strong point there. Are we going to, in the future, look at using something within the community to provide that, so that their school friends can visit them if they are younger people at end of life? Potentially, if they don't want to visit in the home setting, because they don't want that to be intrusive. You know, have we looked at that? And can we, when we do look at the palliative care for end of life for younger people, can we look at it not being centralised to Dumfries? And I'm not being parochial, but we need to make sure that we have these services spread out. If we're offering these community hubs to engage the communities, we need to make sure that we're trying to offer these types of services, if they're not all going to be inpatient services, right across the region, so that people can access them, particularly, like Emma says, the younger generation, the younger people who won't have driving licenses yet to go and visit a friend who potentially could be passing away. So we need to look at that. But my concern is that the care homes, you know, what's to say they're not going to up the cost that they're charging for these beds? Potentially, especially if they know that we're struggling to procure other care home beds somewhere else.
Gary, of course.
There's no guarantees in life, but I think what I can say is, because I've met with every care home operator across Dumfries and Galloway, and I do know that the care home operators that expressed interest, they were looking for 3-year contracts in the main. Now, what we want to do, we want to make sure we've got the right number of beds in the right areas. So we want to, the first 12 months, it's really key. We want to evaluate how these beds are used within 12 months. I think I'll give a guarantee, but based on the feedback from care homes that I've received, I'm confident that they will be looking, for 3-year contracts. I think the other bit I would say as well is, I can't speak on behalf of the care homes. Yes, we have to sit down with care homes to make sure that we're funding at the right rates. Now, we've offered, a certain rate for the flexible beds, which is higher than the standard residential rate. That's one of the things we need to look at over the next 12 months. Have we got the funding for those beds right? I think we need to have an open mind about that.
I think the other thing is that it's been mentioned throughout this process, the fragility of the care home market. And I think what this is doing is it gives us an opportunity to create a degree of stability in that, where they may have not had a consistent income, where perhaps in a situation where we can support that and give them at least a minimum level of income that they're always going to have, that we can utilise and such like. Vivian, you with me.
I'm liking that I'm getting my Sunday name, and it makes me go because I think there's a couple of really good things that you've suggested there. I think in terms of that, I just pick up on what Gary said there around the kind of rates and around where we are working with our care homes. That the kind of rates part around all that, they're all with us on a national care home contract, and that's the terms that we're using, and there's a little bit of discretion for us around what we do if we're looking at things a wee bit differently. But I think there's a kind of wider national conversation that's going on, particularly around care homes and around where that rates are setting over it and where that is. So it's much wider and broader than just Dumfries and Galloway. I think we're quite fortunate, I think, and particularly over the last few years, our relationship with the care homes and the work that Gary and colleagues have been doing with those there means that we're able to have those really open and frank conversations, and we know where there are sustainability challenges. We know where there are other challenges across the piece for that, and the team work together with them and with Scottish Care Home as well around trying to address those. I think just in terms of your question around the younger people and that kind of palliative care space, course, what we're looking at here is particular to adults rather than to young people. But I think when we're seeing things like Steph mentioned, that we're seeing new suggestions coming forward for us already, since we've been talking about the future of these cottage hospital sites is around that kind of day hospice situations and around what that looks like. So I think that's going to be an area pretty quickly that we'll start to really explore as we're looking at that kind of wider strategy and how that would be. And for me, I don't think that is restricted to people that are older and that kind of thing, but actually if that's the kind of spacing in those communities. And I don't know, because I haven't looked at it all yet, but what that kind of requires and what sort of space that is. And there could be a range of different places to be able to do that. I think it's a really good point, and we need to consider this work for thinking about that going forward.
Well, you've got a question?
No, I just wanted to come in about
Oh, okay.
the children and young people's we have got a dedicated flexible team that can cover end-of-life care for them at the moment. So, and they're actually up for an award next week for the healthcare in Scotland awards. In Scotland. It's just something that's flexibly do across the whole region.
Lucy?
Just to say that, also to add that I think not only services have to be fit for the future, medicine and all healthcare professions have to be fit for the future. And if we were to think about two areas that we need to focus on is palliative care and frailty. And we're doing a lot of work locally on that frailty piece, and we are continuing to develop or ideas around palliative care and how best to deliver it. It's a huge challenge, and we're not moving away from it. It has to be tailored to the personal needs. Not everyone wants to die at home. Not everyone wants to die in the hospital. And sometimes the readiness, not only of the families or the patient, the readiness of the practitioners around that end of life element is not there. So if you were to, where do we focus our efforts as a profession, as healthcare and social care? Those two areas would be. So I think your points are very well raised, but in terms of that pediatric, we do have some assurances, great, so much that hopefully our winning. But in terms of just to give us some assurances again, that most palliative care is delivered in the community by our community team, supported by our GPs across the region, and some support Marie Curie community services, including also the palliative care unit here and the teams. Is it enough? No, the needs are so huge that we do struggle to meet them, but we continue to kind of think about how best to evolve. So I know the length of the thing, but it's definitely a good discussion to have, not for today, but for another time around those two areas.
Okay, if there are no more questions, so to Claire again.
Thanks, Chair. For the strategic planning group noted that the public consultation response highlighted concern around the provision of inpatient beds locally. We sought assurance and asked the question of proceeding with the recommendation of option 3, how will this need to be met? Reassurance was given that although option 3 was not the preferred consultation response, the provision of inpatient beds would be satisfied through other models. For example, beds commissioned through care home and Sandhurst that Gary has referred to. And on that basis, the strategic planning group supported the recommendation of option.
Okay, thanks, Claire. Okay, back to members. Do we feel we have sufficient information to make a decision? Yeah. No. Shall we go around, Vicky?
I'm happy to support option 2.
Okay. That's right, this is Jane. Yeah, option 3, Ian.
By recommendations.
Yeah.
Option 3.
Unanimous, thank you. That being the case, and I can confirm that option 3, the social and health, hospital has been adopted. And I'd ask that we endorse the direction as specified and issued to the NHS board. Well, last, but certainly not least, we can move on to item 10, which is the presentation of the findings of the Right Care Right Place programme for Morphy Hospital. We confirm that these findings are amongst the papers that you've already had. I can advise members that have been asked to confirm that the process to date and associated outputs are consistent with the requirements of Direction 2302C to develop a way forward for the use of cottage hospital sites, and confirm it is assured that the process of engagement and participation in the consultation process itself have been conducted appropriately and in a way that is proportionate to subject matter and in line with the planning with people guidance. Also to approve the recommendation to progress option 3, the Community Health and Social Care Hub, and issue the attached draft direction to establish a Community Health and Social Care Hub at Moffat Cottage Hospital, including allocating the budget to deliver. From NHS Healthcare Improvement Scotland have said that we should analyse and consider the feedback from people and communities, recognising that although the options for each cottage hospital were considered as part of one public consultation exercise, there are different nuances and contexts for each individual cottage hospital location, and therefore the decision the IJB makes for each may be different. A respondent to our phone survey said there are 4 hospitals involved in the consultation, but they're not all the same, not one size fits all. And of course, we're taking note of that as we get through these deliberations. Should explain how the hybrid model, which is a combination of options 3 and 4, put forward during the option appraisal will be considered alongside the consultation feedback. However, that isn't an option that is available to us in relation to Moffat Hospital. Should consider how it addresses concerns raised around the capacity for people to receive inpatient care in Dumfries and Galloway Royal Infirmary and the remaining cottage hospitals. An attendee at the Capri in-person event observed there are people in DGRI who don't need to be there, i.e. DGRI, but there's nowhere else for them to go, and similar concerns were also raised at other in-person events. We should ensure that additional impacts for each locality identified through the options appraisal and consultation process are included in updated impact assessments and are fully considered throughout the decision-making and implementation process. I'm going to ask Viv and Steph to describe how these impacts and the impact assessments.
Thank you, Chair. So yes, we have, as in good practice around the quality impact assessment, is that these have changed over time as any issues or impacts that arise or come to our attention, which we've done, and we have updated the quality impact assessment for option 3, which is the recommended option specifically, with any mitigating actions added to that, and we've included the evidence into the section on page 2 around from Healthcare Improvement Scotland. Anything further that arises through the implementation phase will be updated and brought forward with any further development.
Okay, thank you. We've also been asked to demonstrate how the board has taken account through the Fair of Scotland duty the concerns people have raised about challenges to accessing services due to limited public transport, travel, distance and cost. We've discussed that already at quite some length. We should recognise the concerns expressed by some people during the consultation around the perceived erosion of local services and consider how these concerns may be addressed. What it does mean is that if option 3 is supported, this will mean an increase in range of outpatient services and outpatient treatments in the first instance, with a commitment to look at wider service areas for future development as set out at the end of section 15 of the cover paper. We're also asked to acknowledge that during the consultation, people have consistently expressed the importance and high value attached to inpatient beds in local communities. However, and we should pay due heed to that. Feedback, we should give feedback to communities on each of the decisions reached, how we conscientiously considered people's views and the financial considerations and how they've impacted on the decision-making process, and how the issues identified, for example, travel and access, may be addressed moving forward. If the proposals are approved, the Health Improvement Scotland recommend that we consider the following areas during implementation: that we continue to co-design solutions with agreed timescales with people, communities and partners to help mitigate adverse impacts identified through the consultation process. Impact assessments and Fairer Scotland duty, for example, in relation to transport and access. It also recognise that the commissioning process ran in parallel with the public consultation, and this may have resulted in some changes to how the intermediate care model will be implemented. If the changes are substantially different, there may be a need to consider further communication and engagement with affected stakeholders. And we should also think all stakeholders, ensure that all stakeholders are offered the opportunity to be meaningfully involved in the implementation of any decisions that we make. Now going to pass across to Viv and Steph to give us a presentation in relation to Moffat Hospital, please.
Thank you, Chair. Yep, so want to take you back to September 2023 when you issued a direction to NHS and Keith and Galloway to give appropriate consideration to the level of engagement and consultation required to work with community to develop a way forward for the use of cottage hospital sites with suspended inpatient services. We worked with the community closely, and 6 options were developed and approved by the Integration First Board in March of this year for option appraisal and consultation. Those are described within section 3.4 of your paper, page 12, and are the safe plus community health and social care hub, re-establishment of inpatient services, which would for Moffat be open 10 beds, community ownership, closure of the site. As we heard earlier, the hybrid model and a proposal from the Keith and Galloway Council has emerged, and when we asked the community and stakeholders in Moffat around the hybrid model that emerged from the option appraisal, and I think we heard similarly this morning from colleagues from the Community Council that they did not want to consider that option for Moffat, given the importance of the general practice situation there. Want to obviously thank all of the team involved, lots of different people involved in putting this work together, and what we've tried to do in terms of to try and bring some consistency and to try and make it as accessible as possible the 6 different elements of assessment that we've got that have been applied to each of the 6 options, and we've looked at a RAG, bend, amber, green rating system through that. So we've got the options appraisal outcome, and again that was taken statutory involving people who use the services, people who access the people who run the service, deliver the service, and people who manage that. In terms of the consultation analysis for Moffat, that resulted in 250 surveys, and of that 21 were from staff. And we had the financial appraisal, which has been undertaken and provided from our finance colleagues. Workforce appraisal, the operational team put that together, and then with support from the employee director and workforce director at NHS, Keith and Galloway, to make sure that that was in accordance with the staffing Act of 2019. Use the professional advisors to the Integration Joint Board, who are all here and able to speak to that, but further has also been included, as well as the operational management team's assessment of deliverability. As I say, in terms of trying to bring some consistency and a bit of rigour to our assessment objectivity, we've looked to establish a red, amber, green for each of the different elements, and that is described within your paper as well. What we've done within the cover paper is we've presented all of the assessments by the option that is being considered, and within the appendices we've done that on the basis of the different elements, so that you can choose to look at that information in a different way if that's more helpful to you on a particular element. Very happy to take any questions here on that process or how we've undertaken that, but Steph will bring you through the outcome and the assessment first.
Thank you, Bev. So throughout all the 6 elements of assessment, it's clear that options 1, 2, 5 and 6 are not favoured. Option 4 favoured well with some stakeholders in the options appraisal. However, this is an affordable, unsustainable model and is not deliverable. It also does not reflect the ambition of the Right Care, Right Place transformation programme and our local and national strategic direction. As Viv has alluded to, there's been no hybrid model considered under the 6 elements, as that the stakeholders requested that specifically. Option 3 favoured well with stakeholders, particularly in light of the opportunity for relocation of GP premises under this option. Sustaining GP services in Moffat is of paramount importance to both the community of Moffat and the Health and Social Care Partnership. All other options do not lend themselves to this opportunity, and therefore this does present as a significant risk to the Health and Social Care Partnership if other options are favoured by the IJB. The recommendation and rationale is in relation to the assessment across all 6 options. The hybrid model wasn't considered, or the DGC proposal, and it identified that option 3 for Community Health and Social Care Hub is a recommended option. This recommendation is based on the following. It offers greatest benefit overall. It aligns with the IJB model of care, strategic commission intentions, and supports the ongoing transformation of community services. It supports sustainability of GP services within the local area. There's a significant recurrent saving of £699,000 per annum to contribute to the financial recovery plan. Its best value is in relation to 50k per annum for the flexible bed, compared with 160k per hospital inpatient bed. It can be delivered and is sustainable from a workforce and operational perspective. Plus, the public view. Some of the public views that option 3 does not meet the needs for bed-based care. However, there are flexible intermediate care beds and hospital beds within the locality area at Annan Hospital and Watneyville. Shifting the balance of care from beds to home-based services is the direction of travel and is fundamental to the community transformation work ongoing since 2021. Professional advisors to the IJB have expressed the belief that option 3 offers safe, effective care in line with local need, while having potential to improve public health and tackling inequalities. A community health and social care hub has potential to grow and develop in line with the needs of the community, digital capability, future innovations as they arise. There will be opportunities to expand the range of day treatments, outpatient appointments, early intervention and preventative approaches, integrated care and support, extending home teams to combine statutory, independent and third sector, mental health supports, as well as new practices such as holistic person-centred styles of care. Having the GP practice located within the hub setting also lends itself to the joint working opportunities with the practice multidisciplinary team and integrated working for a range of community services. Subject to IJB agreement, plans for further development of services within the hub will be explored with teams and the local people before bringing forward fully costed proposals for consideration and a strategic commissioning decision. Plans will also be developed for GP premises under the primary care programme. Thank you for your attention. We're happy to take any questions.
Thanks for that, Steph. Any professional advisor contributions?
Ladies first.
Thank you, Karen. What a fantastic and timely opportunity. For more than 5 years for Moffat and the surrounding areas in terms of that GP practice and sustainability and continuity of care has been a risk as we had to, as a board, run the practice and then take it back to independent contractors. And we have actually finally found a local contractor that is very well invested in the future of Moffat and the surrounding areas. And this, having premises, is such a vital issue. To be able to run a practice or to run a business or to run any services, you need to have fit premises for working. The ambition of the Lochmeo Medical Group is that they will become a training practice in Moffat. But with that, they need the space and premises fully modernized and fair to actually hopefully support the medical workforce for the future. So we feel that this is a fantastic opportunity, and we're just so delighted that we have come to where we are in terms of that option 3 fitting so well with the needs of the GP practice and Moffat. Thank you.
Thank you, Chrissy. Yeah.
I mean, that's pretty much what I was going to say. I mean, of course it was. It is though, because we agree on that, basically. The history of primary care provision in Moffat for the last 5 to 7 years has not been great, and we have not shot ourselves in glory. And this, now that Lochmaben are currently supporting, we need to provide the premises, because the premises at the moment are just ridiculous. And we have this opportunity, and it's a fantastic opportunity to do this. So it feels very easy to me to help. For the sake of variety, a different professional opinion on this one. But I would just, the only thing I'd add really to what Tracy said is echoing what Liam said this morning, is that we, you know, wherever the decision goes, I can't preempt that, but we need to move at pace because we absolutely need to secure Lochmaven to be the long-term provider.
Cool.
Yeah, and I just want to give that commitment to the community council reps that are still here that joined us this morning, that if the IJB should support option 3, that I will work with the head of primary care, Gracie, finance colleagues and estate colleagues to get a timeline in place that we will bring out and engage with the community, and also report back to the IJB in terms of what that timeline would look like to move at pace. And I would give my commitment to that if that should be what the IJB chooses to support.
Okay. Colin?
I suppose just again, this doesn't feel quite as hard as, you know, in terms of advice given because of the kind of consultation responses and what was so eloquently put by community council today. So absolutely my support is for option 3, because the provision of the GP services is vitally important to this embedding that in community-based models. So fully support option 3.
Okay, thank you.
Once I have very little to say, Chair. The needs presented, you know, by the partnership and expressed by the community, Moffat and surrounding areas are quite clear. Option 3 should be fully supported, in my opinion. That's what the voting members should decide.
Indeed. Open it up to vote members and Chrissy.
Yeah, this one's a really easy one, and I agree with option 3. I thought it was fantastic, the presentation this morning, and it was great to see that the community are going to get a better GP facilities, and also the housing, the whole community are coming together, and if that could be mirrored across the regions, I think the decision for the other ones earlier on today would have been a lot easier, but hopefully that'll come in time. So that's all I really wanted to say. I just think it's great that, you know, the GP surgery is actually going to be a proper one. I think that's paramount in any community, and if this facility offers that and the constituents are happy with that, then, you know, that's good enough for me.
Vicky?
I
How are we going to market it?
say again.
How are we going to market it?
What I was going to say is that actually it's really refreshing to see a proposal where the local community are already so invested in making it a success.
Yeah.
The only question I wanted to ask was, just for absolute clarity for anybody that decides to tune in, what's the risks if we didn't support the practice moving into Moffat Hospital?
Well, I mean, I think Grace is probably best. So if I mean, ultimately, Lochmaven may withdraw their services, and then we have to take it over, which comes at a heck of a cost, and as has been said before, probably not as efficient as Lochmaven provided. And to me, the reputation in Moffat for us would be completely shot. It's pretty sugary at the moment, I would suggest, or it has been said before Lochmaven took over, but we almost, I feel we can't allow that to happen.
Thank you.
Well,
saying something, aren't I? I just realised that for the first time today. No, I did, thank you, yeah. I note that in terms of the capital refurbishment, and it's dependent on capital funding from the Scottish Government. Is there a sense of timescales? But because we do want to move at pace.
So, to respond,
yes, please.
We have done some initial work just to scope that out, and I suppose we have got options that we could potentially deliver fairly quickly. I wouldn't want to commit at this stage, but certainly, as Nicole says, we'll come back with proposals, but certainly within the next 12 months.
No one else? Andy?
Thanks, Chair. If ever it was needed, this is the best example of housing being involved in a health process. To have the houses next door to the new hub is actually like, it's utopia. It's what we've talked about for years. Gracie and myself and others around this table for a number of years about, because you can't separate housing from health inequality. If people don't have decent houses, there people aren't close enough, and that's it there. So it's a commendation actually, because obviously, and this is actually shows how it works. And if you do that, you get the community on your side. And yeah, there's work to do still, I would suggest. Yeah, but we're going in the right direction, and it's a commendation to everybody involved. Thank you.
Yeah, thank you. Any other comments? I'd just like to say, I think it is very evident to me that the community of Moffat have realised that actually primary care is the key to good health.
Yeah.
I think it's good that they've seen that having a hub would be preventative as well. And as a consequence, it reaps benefits somewhere down the line. And I think that to be commended for taking the decisions they did and coming forward with that to us. But if there's no further questions, I'll come to Claire again.
Thanks, Chair. And so the strategic planning group fully support the recommendation of option B, find that this is in line with the public consultations.
Okay, thank you very much. Members, are we satisfied with sufficient information? Yep. Thank you.
Absolutely delighted to support option B.
Thank you.
Yeah, likewise, option 3.
Yep, same.
Option three. Option three.
Option 3.
Option 3.
I'd actually commend option 3.
Commend it.
That's it. Yeah.
Is that better than?
Highly commend.
Highly. Okay, that being the case, can I confirm then that preferred option for Moffat Cottage Hospital is option 3, and that we should endorse a direction to be issued for the NHS board. That being the case, I'm now on to item number 11, which is implications of the intelligence gathered through the Right Care, Right Place programme. And Nicole's got you said 45 minutes, didn't you?
No, just briefly.
4 or 5 minutes was it? All right.
Just briefly, not that it's the only pressure that we've got over health and social care post-COVID, but what we have here through the Right Care, Right Place programme is the pressures on social care and other bits of the health system, but social work and social care in particular, and the impact of that on people's outcomes when they have assessed needs, Stephen, and how we are not necessarily meeting those and having an adverse impact on people's health and well-being. So what I wanted to propose is that whilst I think we do, after the discussion today, have to review the direction that's set out to the NHS in terms of how we measure the performance of the decisions that we've taken, how we continue to adapt to make sure that the outcomes are met, and if not, we bring them here to have that open and transparent conversation, but equally how we develop that, Gracie, with our primary care colleagues to look at what the future is. And I'm really encouraged that we can continue that engagement with our local communities in order to, as per the HIS guidance, co-produce what those community hubs look like. So I think we need to take that away and adapt it. The other bit that I just wanted to kind of highlight, as I have mentioned, Stephen and I have been looking at what for our social care looks like across the Peace and Galloway, and I would want to be working with Stephen and others to bring forward a bit direction in terms of what that looks like to the local authority, so that can report to the IJB. Whilst the local authority have got a commitment to be looking at that work, I think it is important that it's joined up, as we heard very early on, about how all the different bits of this Right Care, Right care programme needs to be brought into context. I think there will be a role for the IJB and others in terms of how we support that direction, in terms of securing financial support both locally and at a national level. Because as we are more than aware, budgets are very constrained and we will need to make some difficult decisions and have some conversations in order to secure what funding might look like for some of those models. So I just wanted to propose, Chair, that as well as adapting that direction to the NHS based on what we've heard today, that just for completeness that we virtually send round a direction for approval by voting members in terms of the work that Stephen and I have already commenced in terms of the vision for adult social care across the region.
That sounds, yeah, sounds good. That, yeah, I think that's the call. Don't think we need to put that to vote, do we? Really care. Listen, before we finish up, we've approved what was put before us today. We've gone with the recommendations. I did ask that we scrutinise, challenge and question, and I really do thank Chrissy. No, I'm not laughing. I'm not laughing. I think it's really important that we don't just be seen to be nodding dogs, that we do challenge it, and if there's a realistic possibility that there's an alternative, that we should explore it. So I'm grateful for that. I'm grateful for the contributions of everyone. It has been a long day, and I appreciate that we have been a little bit repetitious. That has been done because Health Improvement Scotland, that's the format they would recommend. And really it's just to avoid that any potential conflict that might bring today's proceedings into disrepute. So apologise for the repetition, but really it's in our best interest that we do that. I'd just like to thank you all for your participation and patience. And thank you very much, and I'll see you all on the 15th of December.
Yeah, right.